Okay, thank you very much indeed for inviting me. This will be somewhat different because I'm speaking to you from the other side of the Atlantic. I'm Martin McKee, I'm Professor of European Public Health at the London School of Hygiene, as you heard, and I'm also a member of a group called Independent SAGE, which is a group of academics who provide weekly briefings and policy statements and so on, but from an independent perspective. So I could have the next slide, please. I'm going to begin by saying something, some context for the remarks I'm going to make, because I think it's really important coming from outside the United States. Although we speak the same language, sort of, we are in fact very different in many ways that have an impact on what I'm going to be saying. And as I think all of you are aware, attitudes to COVID in the United States are highly and aggressively partisan. The example of the huge gap in vaccine uptake by party affiliation. And that's not the case in the United Kingdom. This is not a party political issue, whether it's mask wearing or vaccination or whatever. Next slide, please. But there are some political divisions. We don't have 50 states in the district, but we do have 4 countries with 4 football teams. And many, but not all of the powers to respond to the pandemic are devolved to the 4 countries. So some, such as the financial aspects, are retained centrally, but many of the other ones are at the level of the individual nation. And what we've seen throughout all of this is that Scotland, Wales and Northern Ireland have tended to act much more decisively than England. And the reason for this is political. Boris Johnson is in a very difficult position. In fact, he's in an incredibly difficult position, as you probably have seen in your newspapers over the last few days, because he's trying to balance the science on the one hand with an extreme libertarian wing in his own party. The members of parliament that supported Brexit have morphed into this COVID recovery group with a similar ideological bent. In general, what we found is the public have been much more willing to take risks, to reduce risks, to act against the spread of the virus than the politicians. So the government had a much lauded Freedom Day in July 2021. It said we're removing all the restrictions in England, but essentially people did not take advantage of that. And there's been high demand for vaccines and testings and adherence to rules without the partisanship that you're seeing. Next slide, please. The other thing to note is that our response in the UK and generally is heavily shaped by what we don't do. So the political reluctance to introduce social distancing measures and others has then meant that there's been very much a focus on technology. So the vaccine rollout is the one area where the government in Westminster is consistently considered as having performed relatively well, although it hasn't done so well more recently. And so every time a government minister is asked about anything embarrassing, which is mainly about parties in Downing Street, they will always end their comments by, but Boris Johnson is doing well with the vaccine rollout. We've also had testing on a mass scale, and testing has been, with lateral flow tests, with rapid antigen tests, has been a key element. And the government at one stage called this as Moonshot Project, looking back at the Apollo moonshot, the massive effort that was taken there as a means of opening up society. And that means that advice to take a rapid test is really for everything. So there's a very high emphasis on taking a test before you go to meet other people. If my children come to see me, they will take a lateral flow test before they come to visit us. If you go out to dinner with other people, many people will take lateral flow tests. Also, there's been a very high emphasis on high rates of genomic sequencing. The next slide, please. And this means that the key principle is that testing has to be easy. And just to remind you, in the United Kingdom, the purpose of healthcare is to promote health and to prevent impoverishment. The NHS is free with minimal exceptions, and prescription medicines are free for most people or at low cost for others who do have to pay working age and so on. So $13 per item, regardless of the cost of the medicine. So it was logical that testing would be free. Except where it is required for foreign travel. If you want to go to France for your holidays and you need a test, then you pay for that in the same way that you pay for a yellow fever vaccine. But everything else is free. So the policy has been very much on emphasizing the maximization of uptake and minimizing barriers to access. Next slide, please. So what are we trying to do with our testing? Well, a number of things, different things. First, we need to diagnose people who are showing symptoms. Then we need to test contacts to identify cases and to reduce transmission. Then we have regular testing to prevent, usually twice weekly, of all health and social care staff. And then we've got what we call test to enable, which is often linked to vaccine certification, where you either have to be vaccinated or take a test, or perhaps both, to get into nightclubs and sports venues. And that's changed over time with the requirement. Then we have test to release, which is really important. And unlike your guidance from CDC, when we reduced the isolation period to 5 days, you can only leave isolation if you get 2 negative lateral flow tests on consecutive days. And of course, many people will not get negative flows on days 6, 7, 8, and so on. And then, of course, we have a program of surveillance in the population. So the next slide, please. That has led us to 4 pillars. The goals lead to these structures that we have. We've got PCRs in pillar 1 being done in public health and NHS labs and in hospitals for health workers and for patients. Then we have a program which is done largely by commercial partners, paid for by the government but free, where people will be sampled at a test site or a testing unit or with home testing. Pillar 3 is antibody testing, and pillar 4 is the research and surveillance I'll talk about in a minute. Next slide, please. So we have a free testing system. You can go onto an app and you can order a packet of 7 tests. Either they will be posted out to your home, or you will go to a local pharmacy and pick them up with a code. This is absolutely free. The postage is free and so on. You can get up to 1 pack every day, 1 pack of 7 tests every day for every individual. Next slide, please. We also have a whole series of surveillance programs. So we have the coronavirus infection survey run by the National Office for National Statistics, the equivalent of your NCHS. And that estimates the number of infections in the population in all 4 nations. And people are tested from randomly selected residential households who may or may not have COVID symptoms. Nose and throat swabs are taken and positivity rates are calculated. We have the REACT study, which is very similar, but that's based on individuals, and that's run by Imperial College. And again, we have the routine prevalence data. We have a schools survey, and we have the Zoe app. Which is an app which is run by King's College. People can volunteer to sign up to it, 4.7 million do, and they track their symptoms, their vaccine uptake, and so on. Next slide, please. Just as an example, the genomic surveillance, we sequenced 20% of all samples, one of the highest in the world, second to Denmark, much more than in the US. I'm not going to go through all our other surveillance systems. Next slide, please. But not everything is good. Our contact tracing has been an expensive failure. The government contracted this out to the private sector. It ignored the local public health directors and the existing contact tracers in sexual health clinics and so on, went to accountancy firms and others. A failure to connect with what was happening. There were all sorts of problems described as shambles in one of the newspapers. It's been a real difficulty. Next slide, please. And partly this is because, of course, diagnosis is a very complex pathway. This is from a paper we published, which looks at the whole process from procurement of sampling, all the things that we heard earlier, actually, about the need to get different consumables and so on. And the crucial thing that has failed in the UK is providing adequate support for people to isolate if they test positive. We give £500, about $700, to people means tested if they need to isolate, but it's not enough and it's not easily available. So that's been one of the weaknesses, but there have been a number of other issues. Next slide, please. So the lessons learned, I'm running out of time, but the key principles are that testing should be as easy as possible. The test must be free. We have no black market because there is no market, no evidence of abuse. The system is struggling at times of high demand, particularly during Omicron, because of the pressure on the laboratories, including the absence of staff in the laboratories, but also the postal workers and so on. The diagnostic system, I think, works pretty well. Genomic sequencing works very well. Overall, Contact tracing has been a disaster, inadequate support for people isolating, but that's a political failure and not a scientific one. And that's another story. And my final slide is a little plug for us in the European Observatory, because we run, next slide please, we run something called the COVID Health System Response Monitor, which includes the United States and which has all the information you could ever want to need to know about what's happening in different countries. Thank you very much.